So my name's Sue Verrilli. I'm the Regional Education Coordinator at the Northeastern Ontario Stroke Network. Joining us today are Susan Bursey, our Regional Director for our program, and Nick Noob, who is the District Stroke Coordinator out of the Timmins District Hospital. I'd like to introduce our speaker this morning, Dr. Ravinderjeet Singh. Dr. Singh is the stroke neurologist at Health Sciences North here in Sudbury and is the medical director of the Northeastern Ontario Stroke Network. Good morning, Ravinder. Thanks for speaking today.
Good morning. Good morning, everyone. I hope everybody can hear me okay. And I would like to thank Susan and Sue for putting this webinar together. I think it's a perfect timing as Moose Factory would be going live with the telestroke, and also it's a quite exciting time for our region because HSN will be providing 24/7 EVT service starting around mid-November. So it's really it's a time to kind of celebrate that the progress in the acute stroke treatment is now in parallel what we are seeing in Southern Ontario, because for a very long time we were lagging behind in terms of the overall stroke infrastructure and also the access to the stroke care. And I think this is a huge progress in the right direction. So the idea of today's talk is to kind of discuss evidence and rationale of acute stroke treatment, and also to touch upon some of the myths and controversies which are out there. And of course, you know, we are now quite used to the controversies given recent experience with COVID-19 vaccine. And so it's not surprising that there are always two sides of the coin, and there are always people who are for and against. And my intention is to kind of give you a kind of balanced overview about where the evidence stands. And so I have no disclosures relevant to this presentation. So I think the first important point is that this is probably the most used slide in the stroke world, and this was based on a modeling by Dr. Saver from UCLA, and the idea was to kind of highlight why it's so important to act quickly in stroke treatment. And here is some of the numbers, and again, they look quite overwhelming, particularly if you see that each minute there are millions of neurons which are getting damaged, and it's similar to the other region like in MI, and the longer you wait, the larger is the infarct size. It's a similar concept, and it's just more a quantitative way of expressing that. So that's kind of a theme, and this is uniform across different therapies. It started with more of a TPA, and then it was applicable to EVT treatment, which is endovascular thrombectomy. And now we are seeing the same concept being used for TIA and minor stroke patient, that the earlier you start the treatment, more aggressive you are in the treatment, the larger is the effect size in terms of prevention. So time is very crucial. So that's one key message. And these are a couple of helpful resources. The Stroke Best Practices guidelines and also AHA guidelines. So, and they are available free, and so anybody could access these guidelines. So today's talk I have divided into kind of three different headings. The first part is to discuss about what's the evidence for the TPA. I think that's the first point in the treatment decision. The second is what we can do beyond TPA, and the third part is what it means to be a telestroke site, and some of the general approach to stroke diagnosis and treatment, more so because now the physicians at Moose Factory and the neighboring health centers would be providing acute stroke treatment. So before we really talk about the impact of the treatment, I think it's important to know the burden. And again, I don't want to bore you with the numbers, but the idea is, or the intent here is to show that it's a huge problem. And even if any therapy has a small effect size, it would translate to big numbers. So that's the key message from this slide. And a lot of time, during the discussion, we hear that, oh, well, the effect size is too small. But that was one of the reasons that aspirin stood the test of time and is still being used despite a small effect size, because the sheer number of the effect it has at the population scale. So although in the trials, the two arms might seem very little different, and if you see many of the stroke prevention trials, you will see the absolute number is about 1% or 2% different between the active and the control arm, but that number then leads to thousands of preventions and millions of deaths being prevented. So that's again a second key from the slide. And so now when we are using the therapy, I think there are two key points to know that in case of strokes, most strokes are ischemic, I would say close to 85%. And most ischemic strokes are due to a demonstrable occlusion in one of the intracranial arteries. Of course, in some cases, the occlusion may not be evident. Either by the time we acquire the image, it has already recanalized, or it could be a very small vessel occlusion, like in patient with lacunar stroke, or it could be an extracranial occlusion, but does affect the flow. So at the end, there is some degree of focal brain hyperperfusion as part of all ischemic stroke. And in most cases, we can certainly demonstrate the occlusion. And it also depends on the modality which you use. So it makes sense if clots are what is responsible for ischemic stroke, is to use the therapy which lyses the clot. And again, if you look, the intent is that once we recanalize the occluded artery, you can reduce the size of the stroke, and therefore that translates into a good neurological outcome and overall reduces the stroke mortality. And another key point which I wanted to highlight here is that the outcomes, which I'll be discussing later, are slightly different compared to some of the other trials which use the TPA. For example, in MI trials, the outcome typically were mortality related. And so those are hard outcomes. But in stroke, unfortunately, most of the effect are mediated by the disability and the quality of life. So therefore, it makes perfect sense to incorporate disability as outcome measure rather than just making your decision based on mortality. So the key theme for any stroke treatment is to achieve rapid, effective, sustained, and safe cerebral reperfusion. So the idea is to open the artery as quick as possible, and if that artery could stay open indefinitely, that's the perfect treatment. But unfortunately, that doesn't happen with many of the therapies, and that was one of the reasons that in MI trials, the aspirin was subsequently added and heparin was added. That is to increase the sustained opening of that artery. So similarly, in stroke also, we need a therapy which is not only rapidly effective, but also has a sustained effect. So again, I'm highlighting the part sustained. That's the most relevant to the patient, because if the therapy has an early effect, but the effect then wanes away, then at the end, there's no net clinical benefit. So, and that is also the reason that the stroke outcomes are captured not immediately after the stroke, but a few months after the stroke. And the second part, when we are trying to analyze the evidence, is that it's not only the therapy which contributes to all the mortality, there's also a direct impact of the stroke itself in terms of overall medical complications. So in the ideal world, we don't want any complications in either arm. We just want efficacy of the treatment and compare it to the placebo. That's the ideal setting where you compare it against the placebo and you just see the effect, and that's the ideal. And there are no adverse effect in either treatment arm. So that's the best way to quantify the actual effect size. But unfortunately, both the placebo arm and the active arms, they end up with having different sorts of complication, which kind of confounds the your assessment as to the what is the actual effect size. So so there's a lot of skepticism about using TPA, and it's less for the EVT because the efficacy was unquestionable, and some of the reasons were that not all the trials showed consistent positive outcome. And I'll be discussing that some of the reasons were related to the medication itself. So subsequently, because we never used streptokinase with stroke treatment, it really doesn't make sense to include that in the analysis. And more recently, there was a systematic review, which I'll be discussing, which used only the altiplase, which is what we are using today, to see the actual effect size. Because when we combine all the trials using different thrombolytic therapies, you really start to lose the sight of the real effect. The second biggest problem in widespread uptake was the safety concerns. Everybody was concerned that the risk of bleeding into the brain is much higher than the benefit. The third, of course, was the cost analysis, and this had partly to do with the reorganization of the healthcare system and the resources which are being used, and of course the convenience, because as I highlighted, everybody was pressing on the time that we need to be fast, and that does impact the resources, because then the emergency physicians have to attend a stroke, although there could be a competing other patient with trauma or other conditions. So it has a huge implication in terms of resources. That was also kind of one of the reasons that uptake was slower. And if you see, the uptake is much quicker in centers which are academic center or larger volume centers where there are dedicated stroke teams, because there the effect on the resources are not, especially in the ED resources, are not that huge, where the stroke team kind of takes over and treats the patient. And the other convenience factor was the amount of information you need or the data you need before you make the TPA call. So even cognitively, it was quite challenging, and ensuring that the quality stands, and I mean the time metrics, you meet the deadlines for the door to needle, door to CT is also met, was also causing issues. So there were a lot of reasons why the uptake was slow, and of course there was also discussion about that if there was flaws in the clinical trial design. But there has been now several trials with rigorous peer review, which showed that that's probably less of an issue. And also industry involvement was widely discussed, and at times, I'm surprised, because industry is crucial for most treatment, because that's where all the manufacturing happens. Of course, there is some degree of industry involvement now. Of course, in certain cases, there is truly a bias related to that, but it becomes difficult. And at least because I was never part of those trials, I cannot really address the question as how much was the industry influence on this. And so again, going back to the trial, the unclear efficacy was partly related to the sample sizes. Many of those trials were extremely small, and they use very different treatment protocols, different endpoint analysis, and even the time of endpoint analysis was unclear. Some trials used outcomes at 1 week, others use at 30 days, other 90 days. Of course, we do know that any acute treatment is associated many times with early mortality, or many times all the procedures, if you see in the short term, because of the procedural risk, is associated with the higher mortality or adverse events. But in long term, it does sustain. And if your time point is too early, you are only capturing the bad outcomes, and you're not really able to see the sustained effect of that therapy. So again, very important to consider that it's not only the early improvement which is crucial, but also a sustained improvement. The second is the questionable safety, because there were a lot of bleeding in those early trials. And part of that explanation was that those trials, some of them didn't even require CT to demonstrate that this was not a hemorrhage, which you're thrombolizing. And the second was that even if the CT was done, the size of the stroke was not taken into consideration. The third was that people were allowed to get into the study even several hours after, like 12 hours or 24 hours after their stroke. So that was one of the earlier trials which showed a very high bleeding risk, but that was taken care of in the subsequent trials, starting with the NINS trial, which reduced the time to treatment to under 3 hours. So once we have a background as to how the evidence really is analyzed, the second part is, does TPA really work, and do we have a good explanation from the earlier preclinical studies and early experimental studies to a large trials? And the answer is yes. And we do know that there's a biological plausibility because the TPA, it enhances the plasminogen to plasmin activation, which in turn causes lysis of the fibrin. So there is a clear biological plausibility, and this has been shown in vitro studies and stroke models of animal models of stroke, which clearly show that if there's a clot and you can lyse it, and you can actually see it lysing by doing repeated angiograms or doing histological examination. And then there were earlier studies, human data, which was piloted mainly to look for as to what's the right what's the right dose, and at what dose you start to see the bleeding complication. So those were the earlier trial, and they also clearly showed that there was a signal for benefit. But to really show the benefit, we needed a large trials. And this is the current landscape of all the trials I've put together. And these are the systematic reviews of all the trials. And I would suggest that this would be a good resource to review, because in all these systematic reviews are not group level meta-analysis. They are patient level or individual patient data meta-analysis, which is very crucial, because what it really does is it puts all the patients from all the trials. So it really, first, it mixes all the population groups, and two, it really provides enough sample size to really test the effect. So these are the currently close to 20 trials which has been published both for EVT and TPA, and interested readers can certainly review these evidences. Now, is the TPA effective in the clinical trial? Of course, we have now the in vitro data, we have biological plausibility, we have animal studies, we have early human studies, but do we really have a good trial? So NINS was the first, one of the first trial, and what most quoted trial, because that's where the transition happened to TPA care. And what it shows is, this is one of the table from that study, and what you see here is the modified ranking scale, which is a scale which assesses neurological disability. It ranges from 0 to 6, 6 being death and 0 being for recovery with no symptoms. And then you have in between scores. And usually anything which is 1 and 2 is considered a good score, because patient, that means is ambulatory. And in this trial, they use a scale of 0 and 1, which means the patient needs to come very close to the normal state. And here what you see is there's about 13% difference, absolute difference between the two trial arms. And this was seen in the part 1 and part 2 of the trials. In part 1, they were designed in parallel, and the idea was to gradually increase the numbers so that the efficacy could be seen clearly. And if there was harm, the second part of the trials would not be conducted. And what you see is that in both, it's a pretty consistent that there is a benefit, and it is more robust in both the early and the late window. And in this particular trial, the early and the late was 0 to 90 and 91 to 180 minutes, which is within still 3 hours, so which is considered very early as far as the overall stroke treatment is concerned. And then there were 8 other trials which were combined with this trial to do this meta-analysis, which was patient level and published in Lancet 2014 by Emberson et al. And what it shows is that in the first 3 hours, there's unequivocal clinical benefit. And you can clearly see that it doesn't cross this 1, so it's clearly superior than the without treatment. So that is a placebo arm. Between 3 and 4.5 hours, again, there is a clear benefit. Of course, it's less robust than under 3 hours. And once you go beyond 4.5 hours, you possibly have some benefit, but it's really crosses 1. So the confidence interval is quite large. So you're not very certain. And although if you see beyond 4.5 hours, now there are 3 trials which show that if you select these patients optimally, you can still derive benefit. So again, speaking to that patient selection is very crucial. And the effect is seen in both younger and older population. Effect is seen irrespective of the stroke severity. Of course, once you go into very severe strokes, the numbers are quite small to really show the true benefit. The other interesting paradigm or way of demonstrating TPA efficacy is to really see if you give TPA, you do a baseline vascular imaging and then compare it to the follow-up imaging and see has the thrombus recanalized, and if the numbers are higher in TPA, then TPA at least works. And so this was the analysis of the ESCAPE trial, which is an EVT trial. And what I want to highlight is this arm, which is the medical arm. And you can see the patient received TPA versus no TPA. And you see here, there's clearly very high recanalization rate. Now, I should mention that in patients with large vessel occlusions, the recanalization rates are very small. So when I say very high, it's in a relative sense, although in the absolute sense, it still looks close to 40%. So it's not a big effect. But if you see no TPA, it's extremely small recanalization. And we do know that the recanalization translates into the functional outcomes. And the another approach to see if the TPA really makes any difference is to look at the early window TPA trials, EVT trials, and the late window EVT trials. And this was called as late EVT paradox by Dr. Elbers from Stanford. And what it shows is that the effect size looks actually much larger in the second, on the second side. If you see the late window patient, the effect size of the endovascular treatment looks very high compared to the effect size on the left side, which is the early window trials. That's not because the EVT is more effective in a later time window. That is because if you see the control arm in the Hermes early window, about 27% had good outcomes, compared to only 15% in the later time window, suggesting that there is some explanation here. And one of the reasons is that most of these early window trials used TPA. And late window, of course, because they were beyond 6 hours, none of that used a TPA. So one of the reasons could be the control group received TPA in the early window and not in the late window, explaining one of the reasons that why the effect size were larger in the second cohort. So although if you just look at the trial, you might say, well, the EVT works better in the later time window, but actually it's not the EVT works better. It's just the effect size is more robust because the behavior of the control arm. This was another study, which was an observational study, which used thrombus as a baseline and then looked at what is the thrombus features which influences TPA outcomes. And what it means is that more porous the thrombus, the higher the likelihood that a TPA would work, because the TPA is able to permeate into the thrombus. And so the residual flow, and you can see here, these are one to the right, top right is the residual flow, and no residual flow in the M1 segment of the MCA. So what it means is that if there is an M1 thrombus, and in one group there is some residual flow through the thrombus, that is contrast is going through it, and in the second group there is no residual flow, you can clearly see patients who have residual flow has a higher recanalization rates with the TPA. And this works across the different segments of the intracranial circulation. So whether the clot is in M1, M2, proximal M2 or distal M2 really doesn't matter. As long as there is some flow through the thrombus, it is going to recanalize more. So overall, what I'm trying to highlight here is that we do have angiographic data which clearly supports that the TPA does work in vivo and clearly has a higher recanalization rate. And so the next question is this applicable to outside the trial setting? And so that's the efficacy of the treatment in general community setting. So there were two major registries which are crucial here. One is called STARS registry, because once the TPA was approved by the FDA, there was a need to set up a registry to ensure that we monitor the efficacy and the treatment in the real world setting. And what it shows is that the favorable outcome is quite comparable to what was seen in these trials. And this is the Canadian registry, which was led by Dr. Hill from Calgary. And what you can see is the excellent outcome, which is MRS 0 and 1, is again very similar to what was seen in this active arm. So even in the real world data is concordant. And I should mention that these were several centers, like in the cases registry, there were close to 60 centers which participated, suggesting that it's not only the high volume academic center which translates into better outcome. It's all the stroke centers which are able to offer TPA contributes to better outcome in TPA treated patients. And the other issue was the safety issue, and of course there were higher rates of ICH, and this did translate to increased mortality. And if you see that at 90 days, about 17% of TPA treated patient died compared to 21 placebo treated. So if you see that still the mortality is lower, but of course this was not statistically significant. And again, one of the reasons was that the small sample size. And at 3 months, about 2/3 of the patients who had a symptomatic hemorrhage, intracranial hemorrhage, died. So if somebody gets a hemorrhage from the TPA, the mortality is quite high. And this was also noted in the subsequent observational studies, and which I will show in a minute. Here, again, I want to highlight this part where you will see the odds ratio, which is if you give the TPA and compare to the treatment arm, there is almost 10-fold higher risk of fatal ICH. But what it means in absolute terms, you see the number of patients among 787, 22 had fatal ICH in the early window, compared to 2 in 762. Now compare this with the benefit, which is 259 among 787, so 32.9%, compared to the placebo 170. So if you see the absolute difference, it's much larger in the benefit side compared to the harm side. And that's one of the key parametric when we are trying to assess the risk versus the benefit from the TPA. And again, here, what you see here is the early mortality is higher. So in the first 7 days, so if this trial had assessed the outcome at 7 days, clearly the trial would show that there's overwhelming harm. But once you wait and wait for the acute difference to resolve and look into the long-term benefit, then you clearly see that there's no real difference between the two arms, or rather, they're pretty similar in terms of the 90-day mortality. So, it's crucial not only in analyzing TPA trials, but also in analyzing many of the other trials, including carotid stenting trials, carotid revascularization trials, because the early peri-procedural risk is certainly there, and if you assess the outcome too early, there would be no real benefit. And this is also highlighted in the PFO trials, where you see that the initial 3 trials were negative, and then about 3 years later, there were 3 different trials which were clearly, or rather 4 different trials which were clearly positive. The major difference between the 2 strategies was the duration of follow-up. So again, highlighting that not only it's the outcome, but when you capture the outcome is important. And the safety issues were also addressed in all the major registries. So this STARS is the US registry, cases was the Canadian registry, and SISMOS is the European registry. And you see this SISMOS is one of the largest registry, and what it shows is that consistently actually much lower mortality than what was seen in the trial. So remember, in the trial, it was close to 16 to 70%. 30-day mortality was 13%, and this is 30-day. So it captures most of the excess early mortality. And in the cases which are Canadian, it's 22.9, which was 90-day mortality. And in SISMOS, it's 11.3, which is again lower than what was seen in the trial setting. The ICH rates, surprisingly, were also lower. And if you see, it's about 3.3% compared to close to 6% in the trial. In Canadian, it was 4.6, and in case of SISMOS, it was 1.7 if it was captured at 24 hours, or 7.3 if captured at 7 days. And again, suggesting when you capture the outcome is also crucial, but it's still well below the what was seen in the initial trials. So once we assess that there is a benefit and there is a potential harm, so where do we stand and how do we calculate some of the numbers? And this is a very interesting way of looking at it, is that if you dichotomize the outcome into good and bad, then sometimes the effect really doesn't capture, because patient doesn't really have binary outcome. Many of the patients stand not at the extreme, but in between those extremes. So it makes sense, rather than just assessing a binary outcome, it makes sense how the TPA changes somebody from one strata to a different strata. So that means from one disability level to a different disability level. And if you consider all 7 levels of modified Rankin scale, which is 0 to 1 or 0 to 6, so including 0, it becomes 7 levels. You need to treat. The benefit for per 100 treated patient is seen in about 32.3 patients, and harm in that setting is seen in 3.3. And in the slightly later time window, which is 3 to 4.5 hours, the benefit, of course, goes down, but the harm is pretty much the same. So the overall effect size certainly goes down, but there's still an overall benefit. And again, just putting into perspective, if you treat 10 patients, 1 would get benefit in 3 hours. Now, of course, the effect size is much more robust in TPA trials, which is 5 in case of early window EVD trials and 2.5 in late window TPA trials. Compare this to the MI treatment, where you need to treat 43 patients within the first 6 hours to prevent 1 death. So again, it's not really comparing apples to apples, but it really just gives you a sense as to how much is the effect size. And so now we do know that the treatment works, and the next question is, how quickly we need to act, because all the treatment for occlusion anywhere in the body is very time sensitive. And this is the analysis which shows that in the TPA treated patient, the longer the time to treatment, the less is the odds of a better outcome. And at around 5 hours mark, you really start to lose any positive effect. So that actually correlates well with the 4.5 hour time window. this is the EVT, and in EVT also, the early window trials, what it shows is that close to about 7 hours, you start to lose the effect. But if you select the patient appropriately, you can extend this benefit to a later time window. And that is what was shown in the late window LTPH trial and late window EVT trials. And of course, we will discuss some of them, but not all that. And I'm more than happy to discuss this during the discussion part. So the theme here is the act fast, and that brings to actually that screen for the large vessel occlusion. So we need to act fast for the TPA, but also we need to act fast to detect the large vessel occlusion. And act fast is also a LVO screening tool. And I'm pretty sure you guys are quite familiar with what the act fast stands for. So it's basically the arm, chat, and tap combination. So it's designed to assess a large vessel occlusion. And if you see here, there are several ways to detect a large vessel occlusion, either pre-hospital or in the emergency department. And one of the provincially accepted LVO screening tool in Ontario is Act Fast, while in Alberta they use LAMS. And LAMS is based on Los Angeles Motor Scale. So, and there are different other scales. And if you see here, the sensitivity is quite decent to detect the large vessel occlusion, as also the specificity, and the positive predictive values is also reasonable. So once we have selected the patient for the TPA, I mean, we need to also consider that if we found the large vessel occlusion, either based on the screening tool, which is what will be used and in the field to develop the bypass protocols, and which are already we are working on, and also in the, I think in the Moose factory setting, it'll be crucial, because that'll give an idea if this patient has a high likelihood of large vessel occlusion. And at the end, it'll be the imaging which will determine whether the occlusion is present or not. But we might use this tool to for some of the patient transfers, which we are considering. And recently we had a discussion about that, whether some of the communities, it makes sense rather than transferring to Moose factory if they are Act Fast positive, and it doesn't look like that they'll be able to make it to the 4.5 hour time window, than to directly transfer to HSM rather than sending to Moose factory and then transferring here. And so the EVT, again, I don't have to really go over the details about EVT, but what it shows is this is the meta-analysis by Mayank Goyal from University of Calgary. And so what was done in this a systematic review was 5 landmark trials were combined together. And what it shows is that irrespective of what kind of patient you select, you consistently see the benefit. Of course, in some cohort, the confidence is not that robust, but it affects across the NIH stroke scale. Irrespective of the clot location, whether it's the ICA or the proximal MCA involvement. It is based on whether you're early or late. There is clearly an effect size, and also in tandem occlusions where you have a concurrent extracranial occlusion. And this is another way of just showing it that irrespective whether the patient received TPA or not, you still see the benefit from the EVT. So it really doesn't matter whether the a patient is TPA eligible or not. Patient could still be EVT eligible. And in the late window, also you see the similar size, and I'm happy to discuss how the late window treatment works. But I'll have one slide which I'll show. So how do we select patients for EVT? And so in the early window, it's quite straightforward. We look at the non-contrast CT. We look at the CT angiogram. If we see a big clot, which is a large vessel occlusion, and here is what large vessel occlusion means, which is the distal intracranial internal carotid artery or one of the major MCA branch, and it has a small core, which means it has a small stroke, and patient has sizable or significant stroke severity, then it's a pretty standard and simple criteria to select these patients for EVT. In the late time window, it becomes a little more nuanced, but I believe there's no perfusion software at Moose Factory. So we'll have to really depend on this criteria, which is early window criteria, and extrapolate it to the late window. And then it'll be the telestroke physician and the EVT physician will be making a call in the absence of perfusion data, although perfusion data is required to select the patient in late window. And in both the cases, the telestroke physician would be able to assist a physician in Moose Factory to make the call for EVT transfer. And for basilar artery, which is the posterior circulation, there were a couple of small trials which showed, really there's no benefit, but it's unequivocal that most centers, they treat the basilar artery occlusion when patient has significant deficit and presents early. And so what it means to you to become a telestroke site. So I'm just gonna rush through some of the key slides here so that we have a little more time for the discussion. And you're welcome to stop me at any time if things are not clear. And so I'll just walk you through how the process looks like and where we need to really stop, take a pause and think and collect more data before moving on to the next step. So most of the encounters are either directly the patient walks into the emerge or is picked up by the EMS and then transfers. Really, the patient might go to the clinic and from there comes to the emerge. And so once the patient is in emerge, the patient is seen in the triage. And the triage, most important, is to suspect the stroke so that an early stroke code could be initiated. And the easiest way to remember this is that any acute focal neurological deficit, make sure you run your screen, the FAST screen, and in a FAST is positive, you activate the code stroke. It's important that we have to be familiar with some of the mimics for the stroke, the common being migraine, seizure, and hypoglycemia. And so always do check the glucose first, and if there is significant hypoglycemia, to make sure that it's not the hypoglycemic episode rather than the stroke. So once the stroke is suspected, of course, the stroke team gets activated, which could initially include only the ED physician in Moose Factory. So the ED physician, when sees the patient, these are the 5 key questions to be addressed. Of course, we want to confirm if the suspicion of the stroke seems legit. And the second is suspect type of stroke. Now, it's often clinically difficult, but if you want to, you can certainly, there are some clinical markers to suggest ischemia versus hemorrhage. But given that we now have a very easy access to the CT, I mean, that's not a very crucial point because the non-contrast CT is able to distinguish the two. The third is the suspect large vessel occlusion, which is based on the ACT-FAST screen tool. And be familiar with the stroke mimics and chameleon, where you can have a non-stroke-like presentation of a stroke where a patient just present with acute confusion and might actually have a language impairment. So it's important that these are the sequential 5 steps we go through, and generally they are fairly straightforward. And usually takes about 3 to 5 minutes to determine if this is what is this the patient we are dealing with the stroke scenario. And once you suspect and once you confirm that this is likely a stroke, these are some of the prerequisites which will help to expedite telestroke consult. And so one of the key things is that we have to collect a quick history, mainly the time of onset. And if the time of onset is not clear, then the last time a patient was seen well is the most important time stamp we get. What are the key symptoms and with which the presenter is presenting? Mainly the language, motor, sensory, and vision issues. And comorbidity, especially if there was any recent stroke, MI, surgery, or prior bleeds. So there is a quick rule in and rule out criteria, which I'll go through. And medication, particularly the antithrombotics in the last 24 to 48 hours, if there is any antithrombotics used, whether it's antiplatelet, anticoagulation, or heparin. So quick focus exam, first is the vitals, most important is the blood pressure, assess, and of course in the vitals, we want to make sure that patient is stable, and assess the stroke severity using a standardized scale, which is a NIH stroke scale, and which I'll just show you in a moment. and check glucose if not checked before. And these are the initial blood investigations which are sent, and in most places, the part of the standard protocol, so it's quite easy and they go by default. We should avoid any delay in collecting the blood. If the patient rolls in early and everything is ready, just go to the imaging and you can collect the blood later. Unless the patient is, of course, on antithrombotic, where you need to draw the sample for INR. And assessing the stroke severity is part of like you can do a standard neuro exam, but usually that's much longer, and you're really not keen on eliciting the reflexes or those signs. Here, the idea is to capture how severely the patient is affected. So this is the standardized 11-point scale, which scores between 0 and 42, and the numbers are graded into mild, moderate, severe, and there are different cutoffs which are available in the literature, but generally, practically speaking, anything less than 5 is mild, anything between 5 and 15 is moderate, anything more than 15 is severe. Although in some of the trials or studies, they used 20 or 21 as a cutoff to define severe strokes. And I'm pretty sure there's already education in place for the NIH, and it's very crucial because the telestroke physician would like to know NIH stroke scale and might ask you to help them do the NIH stroke scale. So becoming familiar with the NIH stroke scale is crucial. At the end of this assessment, we are left with this decision tree, which is if the patient has presented with a deficit, it might have resolved by the time the patient was back from CT. So this is most likely a TIA. The deficit might be persistent, but could be non-disabling, which becomes a minor stroke. And most of these patients in the resolved deficit and minor disabling deficit, they enter into the TIA protocol. When the deficit is disabling, which is usually captured on the NIH, then basically you have to consider TPA and EVT based on the time and the imaging criteria. So the imaging part is composed of two components. One is the non-contrast CT, which is mainly to rule out mimics and hemorrhage. And the second part is the vascular imaging, which is to assess occlusion. Here you can see there's a large vessel occlusion with the left M1, and also to assess collaterals, because the collaterals are the one which sustains the brain as the brain is still ischemic. And so this allows the tissue clock to run differently than the biological clock otherwise. So it's very important to look at the collaterals. It might be very crucial when we are making transfer decisions. And really don't worry about the creatinine. The risk of nephropathy is really low. So unless you are already GFR below 25 or so, it's quite safe to give contrast. And this is a good study published by Dr. Damchik, which you could review. It basically analyzes all the studies which use the contrast in patients with or without kidney issues and showed this is quite safe. So at the end, the decision could be either TPA EVT, where you basically initiate telestroke call to start TPA and for transfer to EVT center. And it could be just the TPA where you initiate the telestroke call to start the TPA, or basically none of the above, where you admit the patient or transfer the patient to the stroke unit and initiates the secondary stroke prevention workup. And as far as the eligibility and contraindications are concerned, it's generally quite simple. We are based on time criteria. So if patient is presenting with acute ischemic stroke, so acute is within 4.5 hours. Ischemic is you rule out hemorrhage on the non-con CT, and you think this is stroke and not a stroke mimic. It's pretty a simple strategy to select the patient. And absolute contraindication is if you see a hemorrhage or active hemorrhage extracranially. So if there is any brain hemorrhage or extracranially, there is a hemorrhage, GI hemorrhage, or there's an active hematuria, that could be an absolute contraindication for a TPA. And relative contraindication, where discretion is used to really either thrombolyze or not to thrombolyze, is based on historical, clinical, imaging, and lab findings. And you can easily review best practice recommendation, and all the information is available there. But again, the key theme here is any recent hemorrhage any recent surgery, any recent trauma. And those are the three key rule outs. And in the clinical part, if you think this is a mimic, especially if you think this is a seizure, it's a rule out. If patient is taking any anticoagulant, that's a rule out. If there are major signs of infarct already, so that means it's an established infarct, it's a contraindication. And if you see potential markers for increased hemorrhage risk, either very low platelet count or high INR, that is a contraindication. And so if somebody has very high blood pressure, it's a relative contraindication. You can see here in number 3 on the clinical, but you can treat the patient blood pressure and make them eligible for TPA. If the patient is over 185, over 110 or 105, you can use any of this strategy to lower the blood pressure. I personally use labetalol, and in some cases we use other combination with the labetalol, and sometimes we also need infusion. But labetalol could be a decent initial choice in most settings, unless patient is extremely bradycardic. And giving TPA is, again, it's a standard protocol, which is available in most order sets. The calculation is as follows. We can give up to 90 milligrams. And if the dose is not maxed, it is based on the weight, 0.9 milligrams per kilo. The first 10% is given as a bolus over 1 minute, and the rest is over 60 minutes. And we monitor the patient closely, and usually this is also standard part of the monitoring protocol. And managing complication, the two of the most important complication is, one is the intracranial hemorrhage, the second is the angioedema. If you see the patient is worsening neurologically or the blood pressure is spiking, you can stop the alteplase infusion, collect a baseline blood work, get a emergent head CT to rule out hemorrhage. And if the hemorrhage is present, you reverse it by cryo, or you can also use tranexamic acid. And you can ask the hematology and neurosurgery consult. And of course, we need to monitor the blood pressure closely and keep it low. And of course, there are other strategies to improve the outcomes. If there's angioedema, get ready to intubate the patient. It may not be necessary all the time, but it's important that there's a high risk for airway obstruction. So you can discontinue the TPA, and if patient was on ACE inhibitors, you can hold the ACE inhibitors. You can give methylpred at 125 milligrams, give diphenhydramine at 50 milligrams, and ranitidine 50 milligrams. So you can give a combination. So it's a cocktail of 3 together. You can also use epinephrine as with the nebulizer, and more recently there is also this selective bradykinin receptor antagonist, which at least I haven't used, and I suspect it's not widely available, but certainly if anybody has more experience with this, can fill me in. And for any question about acute stroke therapy, calling telestroke would be the pathway for Moose Factory. And this may not be quite relevant for Moose Factory, because most patients will be transferred to their nearby stroke center. And Susan can fill me in, but if they need to be monitored, pretty much this is a standard monitoring tool where we try to keep the blood pressure control, and then we do a check CT at 24 hours, and we limit any sort of lines or catheters. And complications, seizure and malignant edema, and especially in larger stroke, is important. And again, in most settings, you may not have to deal with it. If seizure is there, you can load with dilantin and continue the maintenance dose. So any question? I hope we have sufficient time for discussion.
Thanks, Dr. Singh. Brought us right till 10:30, so that's awesome. There hasn't been any questions in the chat. I know that Megan put in something about the NIH training available in Waha, and people can click on a link. So if you have a question now, feel free to unmute, or you can type your question in the chat. And I think we'll start. Karina, did you have a question?
Yeah, I just had a question. I think one of the slides, Dr. Singh's slide, it says CTA should not delay TPA. But I think part of the telestroke protocol is to do the CT head and the CTA together. So I just wanted to get a clarification on that.
Yeah, no, I think that's, I think it may not be very relevant for you guys because now this has become a standard package, CT-CTA. I think this was more relevant in centers which had a lot of resistance from radiology, where these patients will not be, like, not all stroke patient would be offered a CTA. And these patients then have to come back and then go back. So in those cases, just for sake of doing CTA, do not delay TPA. Like if you have non-contrast available, make the call for TPA. And once you start the TPA, you can then transfer the patient back for the CT angiogram. So if things are done as part of the package, which is now what the standard is, we really don't have to worry about that component.
Oh, okay, perfect. And sorry, I just have a second question. We have a lot of patients with chronic kidney disease and often a lot of like end-stage renal failure as well. So I know you mentioned that, we don't need to really necessarily worry about contrast nephropathy unless their EGFR is under 25. And we do have a lot of patients at that level kind of thing. Like, would you still just recommend to do CT head, CTA like together for those, or do you recommend just do CT head for those?
Right. So I think the part of this this puzzle would also be how the patient is. So let's say if the patient comes in, so there's some component of clinical discretion. So if the patient is ACT-FAST positive, I would say just go ahead and probably do the CTA. And but this needs to be informed to the patient that there is a risk that we might end up putting this patient at a higher risk. Now, there is no real evidence for that, but there is a bump in bump in the creatinine level, and these patients might require temporary dialysis after that. So again, we don't have a ton of evidence, and even in patients with really borderline GFR, if they are experiencing large vessel occlusion, it really doesn't matter, because if they will succumb to the stroke, and it's very crucial to really act on a therapy which can potentially save this person's life. And because if there's no survival, I think the kidney point becomes moot. So I would say if the patient has severe stroke deficit, or patient has ACT-FAST, is positive, again suggesting severe stroke deficit, I would still not worry much about the contrast, but I will certainly explain this to the patient or the family that we are doing this, but there is a potential that this patient might have, or this person might have a large vessel occlusion, which is treatable, and so this is a risk, and this is a potential benefit. So I would personally go for it, and I would certainly explain it to the patient.
Okay, thank you.
We have a question from Michael Curlew. Michael, go ahead.
Oh, hi. Thank you very much. That was an excellent presentation. So thank you so much. Just a couple of questions and stuff. One is about, are you routinely doing APTTs on your patients when they come inside for query thrombolytics and stuff? Like, is that a necessary test and stuff that's happening at the larger centers and stuff? The only reason I ask is that we don't have the capacity to do that, an APTT. So it's can we just get away with just the INR and stuff, or do we need both? My other question was just in relation to that there's now some evidence that, if we can open up the window by using more perfusion studies, so like using more intravenous thrombolytics outside the 4.5-hour window, if people have certain features on perfusion, that might be something. Is that something that's a consideration if we have the availability of the perfusion scan and stuff? Because one of my concerns is that the absolute number of patients, just because the window is so finite and stuff, may be relatively few, and if that could be potentially opened up to a wider amount for intravenous thrombolytics and stuff with certain favorable perfusion characteristics.
Right. No, both questions are excellent, especially this. And the second question, I'll try to elaborate in a little more detail. Regarding the first question, no, the answer is APTT is not necessary. Now, of course, if somebody is on heparin, and that also becomes a contraindication, but in certain cases, you can make a case for still a thrombolytic based on APTT if that is within cutoff threshold. The same is true for somebody who is on warfarin. If the if the INR is under 1.7, despite warfarin, you can still thrombolize them. So because heparin is not that a common practice, so I would say you can forego the APTT and it's not really necessary. But because a lot more patients are on warfarin, and especially hearing Karina's comment that if the patient has AFib and they have severe kidney, and most of these patients will end up on warfarin rather than NOAC. So APTT, the PTT and the INR is the most crucial piece then. And yeah, so in most cases, you can just forego the APTT, and even if it is not available, it's not very crucial, deal breaker, but we do get it done here. The second question is about whether we can expand the treatment window. This is something which is being discussed, and I'm not sure if this will be updated in the best practice recommendation. Some centers do. It gives, in the past, it was off-label, so it is still off-label, but you can certainly make a case for patients. So I do this sometime in patients where patient has severe stroke deficit and clot is more distal, so it's not EVT accessible, so it's like M3 or distal M2 and with the very tortuous anatomy, and I know that it'll be hard to do any EVT on this patient. In these patients, you have only two options: either you can thrombolize this patient or you basically let the infarct progress. And in thrombolysis, we also know more distal the clot, more robust is the thrombolytic therapy. It's because it acts better on the smaller clot sizes. So in those cases, yes, I do do the perfusion scan and offer the thrombolytic at a later time window. So it is a possibility. You can do it case by case. It is not approved yet. So, but there is now 3 different trials, so you have good data to really support that decision. So this can certainly be done, and a lot of physicians are practicing this, especially in the setting which I described.
So it's something that if we had the capacity to do the perfusion scan, and let's say we had somebody present outside the 4.5-hour window, and they had, we did the CTA and we were able to get the perfusion study here locally, and let's say the patient presented at 6 or 8 hours and they had favorable perfusion, is it something that the neurologist would consider? Like informed with the patient, of course, with the risks of those procedures, would that be something that would be something that we could potentially consider, just to open up the window a bit, to allow potentially more people to benefit from the therapy?
Oh, absolutely, absolutely, and it'll also depend on, because you'll be largely telestroke size. So it'll also depend on the telestroke neurologist and his kind of take on that late window. So, like, let's say if I'm the telestroke neurologist, I might say that let's go ahead and do it because EVT not an option. Patient has severe stroke, and the perfusion looks very favorable. But we have to make sure that we follow the exact trial criteria for these patients, and we can go up to 9 hours. With the extended window. So no, absolutely, that is certainly a possibility, and we can certainly explore case by case initially. And as I mentioned, unless you are doing by yourself, in most settings, you will still have to depend on the telestroke's perspective, and there are some physicians who are who have already changed their practice, and they do offer it at the later time window, while the other physicians are still waiting for the recommendation to change. And so, I mean, it'll still be case by case.
Great, thanks for your questions, Michael. Are there any other questions from anyone? Feel free to unmute or type it in the chat.
Hi, I have a question. So one of your slides said the contraindication is a glucose above 22. And, like Karina mentioned, we also have a high population here whose glucose is always above 20s. And so would you recommend decreasing their blood sugar before giving TPA?
Yeah. Yeah, so what I'm hearing is a lot of vasculopath and significant diabetes-related complication up north, right? So you're right. I mean, we have two options in this setting. And again, I would highlight that these set of criteria were initially designed to improve the safety of the trials. But there is, a lot of observational data which suggests that you can break a lot of these rules. So that is why they have moved from absolute to relative contraindication. So that means you do have an option to break that rule, and it's not always necessary. And so partly this is clinical discretion. So there were two reasons why why this is discouraged, giving TPA in patient who is severely hyperglycemic. One is that it could be a stroke mimic. So that means hyperglycemia itself could be producing this neurological presentation. So you don't want to really thrombolize a mimic. The second reason is that the safety of the TPA goes down in patients who are severely hyperglycemic. So these patients that are at a higher risk of bleeding. So when I treat a patient with a severe hyperglycemia, and I'm convinced clinically, or I have a clear imaging which shows there's a occlusion, in these settings, we do inform the patient that there's a risk of bleeding which is higher than the usual. But you can still go ahead and give the TPA. So if you're confident it's not a mimic, and two, you inform that the bleeding rates are slightly higher. The exact quantification is difficult, but I would quote that, instead of 6%, I might quote it 8%. So it's based on, again, observational data. So it's slightly higher than what I would be in a standard patient. So as long as those two things are taken care of, you can still thrombolize these patients.
Okay, thank you.
Thanks. Any other questions?
David Beach here. This is sort of going backwards, but some of the concerns that I have about TPA and stroke is that the Ist-3 trial was really the only recent trial, and even it's 13 years old, that showed benefit. And recent reanalysis of the data in BMJ, evidence-based medicine, revealed that there were some problems with the analysis, and that the baseline number of strokes in the placebo group was higher than in the treated group. And if you readjust that, the benefit disappears, although the side effect of increased brain hemorrhage remains. And then the Ist-3 trial, which was done a few years later in 2012, it had nearly 4 times the number of patients as ECAS, didn't show any benefit. Neither did Ist-2, although it was a smaller trial. And, I'm still unconvinced that the evidence upon which we're basing a lot of this stuff is solid. I couldn't follow all the graphs you presented and all that sort of stuff, because of course it's coming off like a fire hose, and I don't know which trials you're reporting them from and all that sort of stuff. But even the alteplase hemorrhage meta-analysis, which you said showed that it didn't make any difference. It went from 0.99 to 1.25, which is pretty fragile, I think, for and it may be true, but I'm thinking, whoa, probably one person in those trials would bump it to the alteplase being more damaging. Alteplase worse, there it is, with just the tiniest tip. And I don't know what they used, which trials they used, because a lot of the other trials, the earlier trials, they were stopped because they caused harm, not because they didn't work, but because they actually caused harm. So anyway, but I mean, a lot of those are throwing out because they're so old, back in the 2000s and 90s. But yeah, I'm still unconvinced that there is solid evidence.
Right.
So anyway, that's my sort of personal feeling on that. I guess one question I would have from a clinical aspect is, when you're going to give somebody the drug, you say, what's your chance of benefit? What's your chance of dying from this? Because when I haven't done emergency about 5 years, but prior to that, I'd tell the patients, right now, your stroke is bad. The chance of this helping you is probably about the same as it harming you. And there's a very good chance that it may not make any difference, as you can see in the trials, when we're talking that it may not make a difference. But I mean, I'm not convinced that has changed. And it may be worth the gamble. Many people would rather be dead and severely stroked out, no question.
Right.
But I'm just wondering where it stands.
Yeah, sure. So now we can certainly address, and so this, which I was mentioning, this is it combines all the 9 trials, including IST, including NINS 1 and 2, Atlantis A and B. It includes ECAS 1, 2, and 3, and 4. It includes IST, which was also published, and it also includes Ist-3 Trial. So it includes 9 different trials. And what I'm trying to highlight here is, I'm not sure, so I would respectfully disagree with the first statement that it causes the same amount of harm as it does the good, and probably there's no benefit. So for 2 reasons. One, what I would show here is that even if you look at the original trial, and I think this is one of the most widely discussed, debated trial, and it has been probably under more scrutiny than any other trial in MI or even antibiotics. And I can bring out some of the data from the other therapies which it works. And again, I'm not trying to defend. This is my personal opinion and take on these trials. So the first point is that if you see in the first 3-hour window, and you see really the effect. Now, there are 2 ways of looking at the effect. You can look at the absolute numbers, or you can look at the percentage and derive some of the odds ratio. And if you see the absolute number here, which is the fatal ICH from all the 9 trials combined, so that means the trials which had high ICH risk to the trials which had positive impact, right? So it's combining all the trials together. And the idea was to really get a good data, because if you see, most of the trials are Atlantis trial, so under 100 patients in each arm. And we do know that the smaller the size of the trial, any effect gets inflated. So if there are 10 patients in 100, that becomes 10%. But if there are 10 patients in 1,000, that goes really extremely low. So you see the size, the sample size can inflate or reduce the size of your, and it could be just that you selected these patients, and these were the earlier ones to have the hemorrhage, which we saw in Tempo trial, and which is still running. And it's very interesting that there were a couple of hemorrhages, and so the number looked so high that they were wondering whether we should consider safety here. But then they continued, and in the next 200, nothing happened. So again, suggesting that the chance not only applies to benefit, the chance also applies to the safety data. So here you see the 22 patients among 787 compared to 2 in placebo who had a fatal ICH. And if you see the absolute difference, how many patients are getting harmed, and it's probably 20 patients, right? And if you go to the benefit, again, the same denominator, 259 compared to 176, and we are talking about excellent outcomes, so which is the MRS 0 and 1, which means patient either had minimal signs or has recovered fully. So 176 compared to 259. So the same denominator, same population from all those trials, good or bad. And you see the absolute difference. So so when I said I disagree is the effect size on the two side is not really similar. If you see you're harming 20 patient difference between the two sides compared to, and if you do the calculation over 100 patients, which are getting benefit, which are getting excellent outcome. Now, this is, we are talking about with a denominator less than 1,000 patients. Now, compared to globally, the number of patients who have stroke or who have ischemic stroke. So the amplitude of the benefit is clearly unequivocal. There's no question about that. The second part is the between over 3 hours, under 4.5 hours. And I do agree that the effect starts to shrink. And that is not related to the TPA, it's not related to the therapy, TPA or EBT, it's related to the pathophysiology of the stroke, because with time, the infarct progresses. And that's the unfortunate in every patient. And that's what happens once you go beyond 4.5 hours. So, but here also you can see that clearly it's on the positive side. There's no confidence interval which is going across one, which says that you're not really doubtful about the effect. Again, going back to the hemorrhage side, the hemorrhage number seems to increase, and now you can see that absolute numbers have increased. So even in the absolute sense, there are far more patients who are getting benefit than the patients who are getting harm. And this, we are talking about fatal ICH, and that's the most relevant complication. And even if you account for fatal ICH, once you go to 90-day mortality, that early excess as a treatment-related excess mortality doesn't translate into overall stroke mortality at 3 months. So even though there was early therapy-related harm, it was so small that overall there was no harm to the trial population. So, and this I'm talking about combining all good, bad trials, all the 9 trials combined. And again, looking at the number treated to harm or to benefit, and here again you can see. So whichever way you put it, it clearly comes to that there's a larger cohort of patients which gets excellent outcome compared to a smaller cohort of patients. Now, if somebody's really risk averse, I mean, that is the reason we always give them the numbers. And if somebody's risk averse, absolutely, you need not traumatize those patients. But I think that this effect size is enough to make a system change. That's one. And two, it is the prerequisite for a overall stroke infrastructure too, because that's a step number one. Once we have an infrastructure for the TPA, then we can build up on that, because then we have the infrastructure, we have the time, we have the speed, and then we can have transfer. We can transfer these patients for even more effective therapy, which is the EVT. So I think I'm not sure if that kind of answers partly and convinces you, but that's all the trial. This is not only cherry-picked trials. It's all the trials, including ECOS, all the ECOS trials, which were combined in this analysis.
Okay. Thank you. I have to. My brain's a little slow. It takes me a while to crank through some of this stuff. I guess my only concern, I guess, with this would be that where you show the ECAS-3, I think there's some doubt about actually those numbers from the standpoint of its analysis. I don't know. You've probably seen that article in BMJ. It was last year. Yeah, so I'm not entirely convinced. I'm still looking.
No, absolutely. I mean, it's right to be skeptical, and especially But I'm surprised that it's been almost 3 decades that we are still not able to come over that skepticism, and partly that has to do with the trials and the number of trials. I'm surprised that despite so many strokes, the sample size of many of these trials were so small, and so the best way to really look at it is do a patient level meta-analysis, which is group all the patients together, good or bad, and put them together and really see where we stand. And I like this systematic review for 2 big reasons. One, it really highlights some of the key variables which were initially suspected were causing the discrepant results in the several trials. One is the stroke severity, that in the treatment arms, the stroke severity was less, NIH stroke scale was less, although if you go, it's actually not really much different. And that might account for some of the benefit. And the second is the treatment delays. There was a lot of concerns around that. And we do know that the longer we wait in the stroke treatment, the less is the benefit. The other problem with these trials were they were based on non-contrast CT. And so they were mimics, there were other situations. We don't know how much was the percentage of these patients, but we think that they were rigorously ruled out. And so that was the reason I was showing the next concept, which is like we are not basing on mimics or patients who are we are doubtful that there's a clot. We are seeing a patients where there's a demonstrable clot, and you give the TPA and then repeat the scan and really see if the TPA works, because that is the best way to really assess that. You see a big clot, you give the TPA and you see if the artery opens up. And so this is the reason that I was showing you this, that large vessel occlusion is the best way to demonstrate whether TPA really works. And there's another interesting way to demonstrate that is that you can give the TPA and put a TCD probe, which is a transcranial Doppler probe, and see how the recanalization is happening. So you can monitor the flow, and as soon as the recanalization happens, you can start picking flow. And that also you can see that the TPA, when you use the TPA or any basically TPA and tenecteplase, those are the most widely used thrombolytics. It does accelerate your thrombolysis rate. Now, whether this translates to the clinical outcome, that is the second component, and which was what I was trying to address in that systematic review, combining all the trials.
Okay, thank you. I better not. I'd love to discuss more, but I know that there's another meeting about the MRI trial that's going to be conducted in our area that started half an hour ago. At 10, I think it was 10:30. So I will not hold you any longer because I know some of the docs will want to get over to that conference call right now. So anyway, but thank you very much.
Thank you.
Thanks, David. It is almost 11 o'clock, so I think we'll wrap up. Feel free to contact Dr. Singh if you have any further questions. And we're glad that you could join us today. Thanks, Dr. Singh, for another really great and interesting talk. And we look forward to seeing you all again sometime.
Thank you, Sue, and thank you everyone for joining.
Thanks, Dr. Singh.
Thanks very much.
Thanks, Dr. Singh. We appreciate it.